Thanks a lot. The microphone is working. Can you hear me on the background? No. I think the microphone is off. So we have to wait. We have to wait, or I take this one, no problem. Is it working? Okay. It's okay. So turn off this one. Yeah. So now I can say good morning after this break. Here is beautiful Ho Chi Minh City. The first time that I'm here, really. And it's a great pleasure for me to discuss with you now the advances in the medical management of male infertility at this meeting. Thank you for the invitations to be here. It's an honor for me, really, to come here. Great pleasure. So my talk is entitled about the medical management of male infertility, old drugs and new understanding. So I'm Pinkera Germa, and today I will synthesize in short the contemporary evidence on pharmacological strategies, how we can select patients, sequence therapies, and to measure the outcome that actually matters the couple. Basically, I have always a different understanding than maybe someone else. It's because I believe that our therapeutic intention should start with the couple. We have to clarify the goals, the timelines, and the acceptance of the trade-offs. We have to stratify the male infertility status, to characterize the comorbidities, and to address modifiable risk factors, as like stated before. Remember, SDF, ROS, varicocele infection, what has been presented before. Highly important. Even if cure sometimes isn't possible, I believe that we have to support the couple in a different way throughout other approaches when we are going to accompany the couple for the RT pathways. So finally, we have to discuss here the infertile man, which is of high risk of genetic transmittable diseases, rather for himself and rather for his offsprings. Only to make an example, in the talk before, Dr. Taras mentioned the Klinefelter syndrome. Are you aware what is the risk for the Klinefelter syndrome man to get a breast cancer? Are you aware that it's 50% higher mortality risk compared to normal populations? So I think it's a fraudulent issue if you are seeking only the patients regarding his infertility, and we are not addressing his risk for breast cancer. We are not addressing his risk for lymphoma. This is 8% higher, so we have to be really careful in counsel correcting. That is what I'm expecting from an andrologist, which is looking the man as it is. Therefore, the objectives today are really pragmatic. We can distinguish the endpoints, we can see the semen parameters, we can see the biochemical surrogates, and the time to pregnancy, and almost importantly, would say, it's a live birth. So the couple is coming not to me to asking me, can I improve my SDF? Can I improve my sperms? No, they're coming here and saying, well, I want to have a baby. Doctor, deal with that. I want to have a baby at the end of the day. So then we have to identify the phenotypes which can have a benefit for medical treatment. We have to discuss which drugs can be avoided, which abuse has to be avoided. It was mentioned before, abuse for alcohol. It was mentioned before in the lecture by Professor Agarwal, again, smoking, also these factors that have to be addressed before you're doing something else. And basically, we should always be aware that what you're doing is quite often empirically. And you have to state that to the patient that the treatment that you're doing, it's not always by high level of evidence, even less it's working. But it's off-level sometimes, and it's a legal issue which you have to address when you do and deal with this to increase the pregnancies. So we heard that the male factor contributes roughly 50%, apparently in Vietnam 70% higher rate than in the rest of the world, but we are assuming 50% is the male factor important. And the causes, they can span by endocrine disturbance, by genetic chromosomal defects, as we heard before, obstructive or non-obstructive azoospermia. We have the situation that we have gonadotoxins, infections, we have systemic diseases, and sometimes iatrogenic causes. So what are iatrogenic causes? If you make a radiation therapy or chemotherapy or something like that, or if you make a surgery with ablation of the testis, then you have iatrogenic causes, obviously, clearly. So you have addressed that. And if you understand this one, that the causes are so multifaceted, then you know exactly that there is not one pathway. So you cannot expect that I'm telling you that's the algorithm to follow up, that's the best way you can do it. I think you have to learn that's really differently for each situation, what you are expecting, and you have to consider what is really the causes for that. Basically, it's quite often good to understand if it's a congenital situation or it's an acquired situation. Acquired, sometimes you can distinguish, you can give any treatments. By congenital, you will have higher problems, but you can deal that. If you know that, you can deal. I will show you right now one treatment option. I'll show you the newest data, how we are dealing that in Austria for these patients. Therefore, a classical pragmatic way would be the distinction between cases where the patient has a hypergonatropic gonadismus or a hypogonatropic hypergonadismus, or is the case that he's completely normal with his values, normal testosterone, normal LH, normal FSH, which is completely different to consider, or is the case that we have a patient which, well, his LH, FSH is pretty normal, and testosterone is borderline, so he's compensated at this stage, and he will develop in the next couple of years a severe disease. So be aware about this distinction. I think that's helpful for that. And therefore, I was thinking about the preparation, how we can distinguish. So I was thinking, what were the treatments? And I would say, well, we can distinguish the treatments in different categories. I believe that we can distinguish by the chemical structure. We can make a presentation only by the chemical structures. We can have a discussion about the evidence, which is stated, we can prove it. We can see if you're using novel therapies, which are empirically or experimental level, or we can see what we want to do by intention. And by intention, I mean, can we do something in the case only to enhance the spermatogenesis, so the production of the sperms, or can we enhance even as the functions, let's say in terms of motility, can we do something if that's the problem, or can we do something to reduce the SDF if we are assuming that there's something else? You see, if I'm speaking about medical therapies, there are different approaches by distinction. And that's the key point that you have to learn how to approach for this process. Obviously, if I'm showing you what the genetic causes, well, it's correct. Most of the genetic causes has no clear treatment because they're congenital. So we can see chromosomal translocation is important or not. It depends. Is it Robertson, yes or no? Maybe it has no impact. You can go on. So the 19 chromosome deletion, it doesn't matter. You can still proceed. If you have Klinefelter syndrome, well, 20 years ago, my chief told me, never do that. And he was honored when I've done the first baby in Austria with a Klinefelter syndrome. And he came to me, Germer, what are you doing with these cases? You're producing Klinefelter babies. And I have to explain to my chief, no, my great chief, that's wrong what you're telling. If you found sperms, you have a low probability that the follow-up, the offsprings of the children will have a Klinefelter syndrome. The difficulty is to find the sperms. So you see, sometimes you can do something, sometimes you have difficulties. If you have a Kennedy syndrome, you will have difficulties because there is a genetic problem of the androgen receptors. There's no way. So what can we do right now? Well, we can distinguish the therapies. Some of these therapies specifically target a precise category of male factor fertility, while others are used empirically and to treat idiopathic male infertility. So our armamentarium right now includes the SERMs, the exogenous gonadotropins, like FSH or HCG. We can have the aromatase inhibitors. We can use dopamine antagonists, highly important, something to look to because they have a huge impact on the testosterone synthesis in case of hyperprolactinemia. And we can target TRT in case of testosterone replacement therapy, carefully in selected cases. So these are clearly chemical structures which are used, some with a different level of evidence, whereas other ones we have discussed, well, are anti-inflammatory drugs really medication, yes or no? Are natriuretics or medication not? What's the level of evidence? I think there's a huge difference what you can do. If you have infertility caused, for example, by the unejaculation, by erectile dysfunction, well, I think PD5 inhibitor, even less not classical indication for that, and even less not in the guidance for that, they're still working, so you can see that one. And then obviously we have another category for medication reconciliation, where you can see how we have to deal with the patients. So you see different categories, different medications can work. Coming back, let's take a look to the therapies to enhance the sperm function in the first trickling of leukocytospermia. This simply means that there are too many peroxidase positive white blood cells in the semen, and over 1 million per milliliter is considered highly significant. So when these activated cells are there, they are producing a high amount of reactive oxygen species, which is driving to oxidative stress, to increasing sperm DNA fragmentation, and therefore to a low fertility. So you see, only to look on the leukocytes sometimes is highly important. Then you have only to see which are the causes for that. Sometimes you can find germs, and like typical germs are chlamydia, Ureaplasma ureolyticum, Neisseria gonorrhea, or Mycoplasma or E. coli. Then you have to treat it, but you should treat it only in the case that you can prove it, and to prove it means that you have to see that you have a culture for that. The culture can be done by the semen, by the ejaculation, and there we say, well, don't trust your lab. Don't trust the lab. That means you have to think about what means that the lab is taking an ejaculation and is trying to make a culture on the plates. And are you really sure that the plates are ideal to make a growing? So even less in the case there's growing nothing means that there's no germs for that. Therefore, we switched times ago over to do an addition for a genomic PCR, a whole genomic PCR that we can see that there are traces. And trust me, we found germs which are never heard by the bacteriology and the findings. So you have to do twice. One is the ejaculations culture in the case of high peroxidase positive cells over 1 million. And secondly, you should really stringent to use a post-experiment culture from the prostate message, because then you can see in this case that you have a clear confirmation and there is a need to treat it. So that is one way. If you're looking, coming back to one of the causes I mentioned, that was the hormonal axis, then we should be aware that the hypothalamus, pituitary, testicular axis on 3 levels, that you have on one side promoting factor, like the kisspeptin, tachypinin 3, or neurokinin, which are activators, but we have even less some substances, some cytokines, the RFPR3, which are blocking. So this can be genetically blocking the neurons, and therefore you have no stimulus. What means that? That is a crucial issue, because sometimes you have a blockage on a certain level by a certain situation, and it can even less be a stress or fever or an illness, a severe illness. Then you have here a blockage of this normal axis. That means you have to figure out where's the problem, because it gives not sense to give a therapy independently which kind of therapy you're looking for, or you're looking at terms if you have a blockage by the hypophysis. Therefore, the first step I would say is to understand that. In the case of a hypergonadotropic hypergonadismus, what's clear, you have a low LH, you have a low FSH, and obviously you have a low testosterone. I didn't write it down because it's so clear. Low testosterone should be an indicator to look for that. Then you have to discriminate before you start on therapy if that's congenital, it's a developmental situation, it's acquired, it's dependent by drugs. So if I'm looking to the data, how many opioids are used in the US states, more than Europe, then they have a lot of cases. They have many cases of hypergonadotropic hypergonadismus only because they're using or abuses this oxycodone therapy so often. Then we have to think about the brain injuries quite often, not in sportive cases or in boxers, in bicyclists, they have fallen down several times. In our region, more the ski sporters, so they don't see that, but they have a brain problem there. We have pituitary problems, which the hypophysis is not working correctly, either by inflammation or by diseases or iatrogenic causes. Then, of course, someone is destroying your pituitary gland, you have the same situation. So The induction typically begins with HG to stimulate the Leydig cells and to raise the intratesticular testosterone. Why is that important? They have the high intratesticular testosterone. So are you aware what means, what you're really doing the whole day? So if you're going to measure the testosterone in the blood, but is that important for us? I would say no, for the fertility it's not important. Important is the testosterone concentration in the testicle. The environment is important. And there's a huge difference. That's around 70 to 100 times higher what you measure peripherically. So what you're measuring in the periphery, in the serum, is not reflecting what you really need for the testicle. So here you have to be really careful what you're thinking about, what you're doing in these cases. And we have to see that there can be a lot of difference, and if the production of the testosterone is not done by the Leydig cells in correct way, there can be 50% of cases by genetic reasons linked to genetic. There are many genes, around over 40 genes, which are linked to this one. Then you have to see how to deal with this. It's completely different from other cases. In the case they have a prolactinoma, it's easily. You can deal with the patient, immediately make him happy because the testosterone is coming. You have only to block the production for his prolactin, and he will increase his testosterone, and the sperms will come back. Therefore, check only the medications. So start slowly with a lower dosage, not with a high dosage. If not, you have a brain problem, there's swelling of the brain. So we are starting with 0.25 to maximal 1 milligram twice weekly or one times weekly, and then you can increase it. And one time you have normal testosterone, proceed with this therapy for another couple of months. Elsewhere, he will fall back again with his prolactinoma. In the case that you have acquired factors, let's think about a testosterone patient would have abuse for testosterone. So what you're doing, he has a normal testosterone, but by the fact that he's using these anabolic medications, and this is quite a 30%, 34%, even less in these protein shakes inside, he will have no sperms. And here we show you today novel data, what means that in the consequence for the patients. So in this case, we would obviously go ahead, simple check what is his latest without any testosterone replacement therapy, his latest testosterone birth. Then we can start with injection therapies 3 times per week, and we can increase that, or additionally we can use, if it's not working, we can use recombinant FSH so that the sperms are coming back. Within a couple of months, you can get here a good factor. Important, and I highlight because I realize quite often for my colleagues, someone is going to use this injection therapy intramuscularly. I would say it's not a good idea because they have a side effects, it's not working. So use it always subcutaneously, then you have a good stimulation effect. Subcutaneous injection is really proven to work. So to make it simply, so you see in the case that you need the gonadotropins as a therapy plan, so you can make an injection therapy, or you can use the HGG, as like stated, 2 to 3 times independently, maximum 3,000, seldom case of 5,000, more or less 1,500, 3,000 is what you're using. Intramuscular, I would say it's not a good idea. Subcutaneous is proven to be better, it's working better. You can add to this one HGG or FSP in the second line. Here's a quite a dispute. What should you start immediately with both together, or in the case of a completely low testosterone, in the first to increase testosterone for 3 months, 6 months, and then add the high expensive therapy with recombinant FSS. So that's a plan which is working. Interestingly, and that's highly interestingly, that someone is now believing and published 2-3 papers that the progesterone, the 17-oxygen hydroprogesterone has to be measured because that can be an indicator if the therapy is working or not working for these treatment arms. So we are right now looking for what if this paper, which is published by an Italian group, is consistently and is a valid methodology. But again, what we are trying always is to increase the testosterone. And one other option, as I mentioned before, is the clomiphene therapy. The older version was the tamoxifen. Nowadays, clomiphene is good. Clomiphene is not expensive, so you can that really make a good prescription for a long time because nothing. I will show you that's not so the efficacy is lower. But it's a good option sometimes to increase only the testosterone, and you can use Clomid because you work on this on the same axis. Again, as I showed before, you're blocking here the negative feedback. Therefore, in synthesis, you are going to increase again your testosterone in the testicle, and you need here the testosterone in the testicle, in the Leydig cell, in the receptor cell, so that the environment is then producing here the sperms, else we have no sperms. Additionally, as another therapy, you have to think about the therapy plan for anastrozole or letrozole. That is even less a good option, I would say. That's working differently because in this case, we are looking forward to block an enzyme, which is typically in the fat of the man, in the abdominal fat, the subcutaneous fat. This you can block one enzyme, and by blocking this one, you have a reducing of the estrogen, and therefore it's a good indication. But be aware, this medication, which is of good efficacy, I would say, particularly if the ratio is indicated to use that, it's not allowed. It's not for this product indicated. So that means if you're doing that, you have to clearly to understand that that's what produced for the gynecologist and not for the andrologist. Even as the same working, same enzyme is there, because we men seldom will have endometrial cancer, so seldom is indication given for that. That implies, obviously, that you have to explain that you're doing an off-label medication, and I would strongly recommend to document this one, that you have discussed this with your patient, and even more, you have to see if you have other enzymes in the liver or fast and slow processor that can block these medications too. In the case of a congenital hypergonadotropic hypogonadism, which is really rare cases, there are genes many involved, and this is a situation where the children has just from the beginning on, it's congenital. So it seems the adolescent boy is growing up differently by a defect in the production, in the secretion or action of GnRH. How looks this by children typically? Well, they have an incomplete puberty, and they can have a subgroup, for then only a subgroup have a Kallmann syndrome, which is genetically clearly defined. In this case, and in the case that he has a normal smelling, he will be normosmic congenital. Here again, you have clear findings with a low testosterone, low FSH, and you have to try now the treatment accordingly what you can do. It's not so often. It's 1 to 10,000 cases, but you can find it. But this in your practice will be around 1% of the cases where you can find it. The gene, I'm over. Okay, I will fast now. The genetic cause are completely different, so that you can see autosomal dominant, recessive, or X-linked. So you have to treat underlying the disease is a GnRH hypophysis problem. So I'm out of delay. That's the reason why the genes in the hypophysis are not migrating, and there we have the problem with the CAL gene and the FGR genes. This is a typical finding from a patient, 18 years old. You see abdominal fatty tissue in high amount, low testicle, Tanner stage 2 with a low penis and typical gynecoid form discrepancy. What you're doing, we're doing 2 tests. We're doing the Relifac test and the Pregnil test. Now I'm out of time, but it's highly important. This you can do in 2 hours, whereas for this test, when you look at the response of testicle, you need 5 days that you can see. If a response in increase of LH or FSH around a factor of 2, you're positive, then you can start the treatment. We have a classical treatment, which normally is done in the case where we have interest. So I'm proceeding some slides fasting. That's important. In the case that the patient had before, remember this one, a testosterone replacement therapy, or he used an abuse of testosterone, which is really high percentage. If you're using the long-acting testosterone undecanoate, the long-acting one, you have a bad chance because it needs long time to recover it. If you use the short-acting every 2-4 weeks, the injection therapy, which we are not using anymore for the last 10 years, you have a better situation. If you use the cream, maybe you have a best option that you can restore it in a faster time to get normal testosterone. And now I'm showing you right now the novice from this year published data that exist in the US, the Natesto spray. You're aware about this Natesto spray? That's a testosterone replacement therapy that the patient is putting in the nostril, 2-3 injections per day and have a normal testosterone. And that's important to understand. Not each testosterone is similar. If you're using this replacement therapy for Natesto, you will see that you have a low suppression of your spermatogenesis. Even less, you can treat perfectly the testosterone in these cases. So you see, the classical dogma from any testosterone replacement therapy should be rethinking, and you should think what you should do. So if the patient needs a testosterone therapy and has finished his fertility issue, then you can use maybe a long-acting, every 3 months injection therapy. If the patient is saying, well, I don't know, maybe next year, 2 years, I want to have a baby, I would not give him this long-acting. I will give him maybe a cream, a daily cream with Mr. Circadian rhythm, or in the future, in Europe it's not allowed, but maybe in Europe we are starting this next year. We can use this type of cream because that has been shown to have no negative effect on the spermatogenesis. And that's highly important. That will be the future thing to address and to know this one. That's a novel treatment arm. So you see, long-acting keeps really long. If you're using nasal therapy, it's faster, and you can start immediately orbis clomiphene, HGA, or the combination therapy to promote again the spermatogenesis, and that's what we are interesting. Independency of the severity of the azoospermia or the sperm count, you should proceed. And when even less, sometimes you have no sperms inside in your specimen. With this therapy, you can get sperms in a second line. You can retrieve a positive microtesis. You can do that hereafter. Don't do that without a stimulation therapy. In this case, you will always fail. And the classical way, now 2 minutes, allow me, if the chairman allow me 2 minutes, then we'll show you one minute, okay? Then we'll show you the classical therapy is, as I explained, to make this injection therapy with FSGs or the combination for this one. What we can do else is this pulsatile therapy. And that's important to understand. That's if you go out and have this information that this is a novel therapy, then you have a winning card, and then we show you what it means that. That is simple. You're using here a portable computer where you can here put inside exactly the dosage, 10 microgram, and you can say every 90 minutes or every 100 minutes you get a pulsatile injection of this medication of the GnRH, and that the patient has here one pot with a needle subcutaneously, and every 90 minutes, if you're putting here 90 minutes, here in the injection therapy will get a release of these gonadotropins. And that's fantastic. That's fantastic. This pot can stay there for 2-3 days. He can go to shower, no problem, it's fixed. And I will show you only the first data. We have done meanwhile 20, and what I show you, this importantly case. All of these patients has been no testosterone. All of these cases has no LH, no FSH. All of these cases are genetically normal. So we are not speaking about Kalman syndrome, normal, idiopathic one. After 3 months, 12 after 12 weeks, 3 months, you see all the patients had regained normally, perfectly testosterone. All of them had normal LH and FSH. And if they have been azoospermic or even less unejaculation, all of them get sperms in the ejaculated, and this could be used for cryopreservation. So that means we did not need to make a testicular operation anymore. And you see, that's increased in the short time. That's highly important. We have done around 20, and that's a working process. So one time you understand what you can do, you can use this pump mechanism because it's more normal than other ones. Because every 120 minutes, normally the man has a release from LH in his body. And if the LH release is not there, then you have only to substitute this one, and you have a good chance to do something. And I can prove it, we have done it more. There have been data in the literature, there have been studies. The past studies have not been so good, but trust me, that's a working situation, and I'm happy if you take these two information, not testo as on therapeutic options outside of the classical one, and this therapy, and so I'm happy and sorry that I ran over, but I think that was highly important to understand it. Thanks a lot.
Yeah, thank you.